yourself, please, and all of your officers.
Tom Binet, Health Minister, if we start.
Cathy Stone, the Nursing and Midwifery Change Lead. I'm representing Tabitha Darman, who is the Chief Nurse of the organisation.
Thank you. Can I just check, is that being picked up with the microphones?
Yes.
It is, okay, thank you.
Ruth Johnson, Director Health Policy.
Andy Howell, Assistant Minister for Health and Social Services.
Andy Weir, Director of Mental Health, Social Care and Community Services.
Thank you. And we do have two officers that you might swap in, and if they could introduce themselves as and when they join the table. Okay, so this is a quarterly hearing for which we have 2 hours, and as always, a lot of questions to get through, we may follow up in writing. Minister, there's one section at the beginning or near the beginning of the hearing, which, if we had more time left in this term of office, would have been a standalone review hearing with you probably on the termination of pregnancy legislation, but what we've done is we've put it into this quarterly hearing, and we're going to handle that slightly differently. Usually we have 1 or 2 members focusing on one section at a time, and we're each going to do some questions on that question area, so you might see a little bit more jumping around than usual on that area. Is that clear? Is everyone happy with that?
Absolutely fine.
Fantastic. Okay, so 2 hours. If anybody needs a comfort break because it is slightly longer than usual, please just let me know. We can have that. Okay, so Minister, just one kind of short umbrella question to begin with, because some of the sections at the beginning are to do with various aspects of women's health. The women's health strategy, further to the panel's amendment to the budget, which you accepted, and we're very, very grateful for that. It was around the women's health strategy to bring that forward in 2026. Please, could you give us an update on the progress of this work?
I have to say, as you know, that's work that's been done by Deputy Howell.
In conjunction with our policy officer.
Yep, I'm happy for Deputy Howell to answer this
I
one.
think it might be easier if
So
you'll get a
we
full
are
update.
definitely, it is work in progress. We want to make sure that women in Jersey are empowered for looking after their health. They need to take responsibility for their health themselves, but we're going to do all we can, or we have been doing for the last 2 years, to just carry on doing that work.
Okay, thank you.
And we're working, there'll be the policy officers are working on the strategy.
Okay, thank you. Is it going to be possible for us to see a draft of that before the end of this term? Even a confidential draft for the panel?
We will certainly be able to share with you. I don't know if it will be in the stage where it will be a draft strategy, but we will certainly be able to show you before the end of the term the key areas of focus of the strategy, because those are very much taken from the findings of the Jersey Strategic Needs Analysis and also review of key and critical areas of women's health and needs from other jurisdictions as well. Okay. So I wouldn't say it was going to be a full strategy with actions, but it will certainly give you a really good sense of what we're looking at.
So our focus has been for the last 2 years on taking a whole life approach for women's health before people are born to when they die, and making sure that we listen to the voices of women and make all the improvements that we can.
Okay, thank you. Yeah, so as and when there's something ready to share in confidence with the panel, we'd love to have a meeting about that. Okay, if you could keep in contact with our officers to arrange that, that'd be great. Thank you. Okay, so I'm going to move on to the termination of pregnancy legislation, which has been lodged with a debate date tabled for the 10th of March. Minister, this is a short time frame for such an important piece of legislation. How are you going to make sure that States members are fully informed about the legislation, that they understand to have a full debate on it?
I assume we're going to have a briefing before the debate takes place. I can hand over to Ruth. If you've got a date, I don't know if you've got a date.
Yes, so I think the date should already be in States members' diaries, and if not, I will chase up on that. But the intention is that there will be a full States members briefing beforehand, and as with other bits of major legislation we do, such as assisted dying, we will make ourselves available as officers if any States members have any follow-up questions or want to have any one-to-one meetings to understand the underpinning policy intent.
Okay, thank you. So if states members want to do that, would they contact yourself
They
Minister, to
can,
arrange
yeah.
that? Okay,
Make
thank you.
sure.
And in terms of the public understanding the legislation, is there a communications plan? How is that working?
Yeah, you can,
Okay.
Karen.
So we haven't organised any public meetings to talk about the termination of pregnancy law. We actually did not organise public meetings during the consultation phase, whilst we had a public survey and we provided opportunities for people to give us their comments and their thoughts on termination of pregnancy. We didn't organise any direct public meetings around it, partly just because it is a very controversial subject on which people are very polarised, in many ways more so than assisted dying, and it felt potentially kind of quite complex to put officers into a public domain of that nature. But what we have done is obviously we've published the law. There's a report and proposition that clearly explains the law. And what we are working on now is some clear Q&As, which will be available on gov.je, which will help people understand what the law is doing and also what it is not doing as well.
Okay, I'm going to move over to my vice chair in just a second, but in terms of Q&As, and Minister, have you had any questions so far that along any particular themes from the public or any
I
queries?
don't think that we've had various questions. I don't know to relate to a particular theme, but you're pretty close to that.
So I have other states members have forwarded to me questions that they have had from their constituents, and the majority of those questions focus on justification of what those particular individuals see as a very liberal approach to termination in Jersey, being underpinned by the current law, and the general approach, I would say, whilst those people don't disclose their views, is that they are individuals who support a very restrictive approach to termination and the provision of termination in law.
Okay, and then your Q&As that you're planning will cover some of these key themes, will they?
They
Okay,
will do.
thank you.
Minister, one of the key articles, I think, is Article 12, which is which is to do with ensuring provision of termination services. And it has a clause in it that says you must take all reasonable steps to ensure that termination services are available with then some qualifications. How do you interpret that?
Well, it means what it says, all reasonable steps. We can't force, as you're referring to people in the hospital service being prepared to carry out terminations after a certain period, because I think that's the difficulty that we're referring to. At the moment, we don't have a team of people that are prepared to do that, and I don't think it's reasonable, but we can't insist that people undertake that work. If we, over the course of time, through the recruitment process, that people come on board that are able to and are qualified and prepared to undertake that work, then that's a provision that would be available. But I said at this point in time, it's not. If it's not something that the people that are doing the work are prepared to offer, then that work has to take place off-island.
And what practical actions are you taking to meet that obligation? For example, training, range expanded to enable the range of services to be expanded?
Well, on that particular one, you can't offer training to somebody who doesn't want to be trained for the job. And because we haven't got extra resources that can afford to have extra people for specific purposes.
Can I clarify? Did you mean training other staff who don't yet have those skills?
Yeah. I mean, has any attempt been made to find people who might want to provide services?
You'd have to have a vacancy in order to do that, unless you're going to take on extra staff specifically. And with current restraints, that's difficult. I don't know if you've got any further
Can I
comments
just
to make.
jump in
Yeah.
that it is very specialised
Yeah.
after a certain period of time of gestation, and so even if you're in England, you would need to travel perhaps to another centre, to a centre of excellence, because we just need kind, compassionate service for anyone. But we're trying to encourage any woman who needs a termination to have a termination early. because
course.
it's much more straightforward then.
But can I just clarify, has any work been done to find out whether there are any clinicians in Jersey who would be prepared to go down a path of
My
trying
understanding
to...
is that has been the case.
Yes.
Yeah, but
And there isn't
at,
any.
There has
at
been
this point in time,
consultation.
there has been quite a lot of consultation. There's
But there
been
is
lots of input.
nobody at the moment who would be prepared to do that.
Okay.
But it doesn't mean that over the course of time, people fall out the frame and you get new staff. And it may well be that that might be something we look to in the recruitment process.
The option, therefore, will be for people to travel to access those services, which is not going to be paid for. So that will be something that a person has to pay for themselves. What cost analysis or modelling was done to kind of work out how much that would cost were it to fall within government, within a funded service?
I can't recall whether I don't know that specifically whether we've undertaken that work, but I think the numbers from recollection are relatively low in any event. So it wouldn't be vast.
But the justification in the document is that we can't afford it. So presumably there is some measure of how much it will cost. Otherwise, we wouldn't know whether we could afford it or
All of
not.
these situations, we were in a discussion yesterday about travel policy, and on almost every issue, you can push the boundaries and say, well, why wouldn't you do this and why wouldn't you do that? And in the end, you end up with a travel policy where everybody gets paid for every element of travel. And I think within budget constraints, you've got to take a really relatively consistent approach to everything that you do. And I'm afraid travel is one of those areas. Yeah, one can forward the argument either way, but as I
But
say,
we will cover anybody who needs to go for medical reasons.
Yes,
For a medical
absolutely.
situation, yes.
Okay. I think I'm right in saying, Minister, that in Guernsey, which has changed its law to accommodate a broader time frame for termination, they send all their patients who are beyond 12 weeks to the UK. Do you know whether that is the case or not?
It is the case. I've read that, Sir Philip, and that is my understanding.
And I mean, so is that going to be the position in Jersey for the present?
At the moment, it will be.
Yes.
Yeah, as I say, it's not inconsistent with some general hospitals in the UK. Beyond 12 weeks, they would send patients to specialists.
What's the justification of increasing the time frame, which is a controversial issue?
I think to take away the stigma, which perhaps so it will be lawful, whereas at the moment it's not lawful in Jersey, and it's to help women in those situations.
It is lawful across the UK, and if
Yeah,
I'm
still
not wrong, it's up to 24 weeks in the UK. We've been a little bit more constrained in Jersey, to the tune of 2.5 weeks, is it?
So the amendments to the law, because of the current restraints we have on the service, mean that changing the law for most women will not have an immediate benefit. However, if it was in future to be possible to provide an on-island termination service at later gestation periods, that clearly provides a benefit. Planning for the provision of a termination service at later gestational limits that are not legal is problematic for us. So there is a sequential process that has to be gone through in the first place. We would not, in any other areas of healthcare, actively recruit for staff to deliver a procedure which was contrary to the law. So amending the law provides for decisions to be made about changes in future workforce in the first instance. Even in the event that we are not able to recruit a workforce that can choose to and safely deliver termination services in Jersey, it is nevertheless the case that amending the gestation limits does help remove some of the stigma that is associated with terminations, and particularly with later stage terminations. And when we went out to public consultation for the second round of public consultation, because we understood the dilemma about the air gap between the legislation and the service, we actually asked people if we should bother amending the law given the existence of this air gap. And people resoundingly came back in the public consultation and said to us, yes, it is important that you do that.
Can I ask a follow-up in terms of our current legislation where somebody travels off island to access a termination that's, say, for example, at 14 weeks, can they face prosecution in Jersey under our law?
No,
I don't believe
no,
it, because
they can't.
you would be having your termination in the UK under the UK law.
Can I can't think of the word, but practitioners locally help to facilitate that or have conversations, recommend where you can go in the UK currently under our law?
I think at the moment they can produce a list of places where it would be possible to go to have the service, and I think that's what they do.
But they're limited.
But then they're limited.
If the law changes as it's being proposed to, can they help to facilitate it more?
You can have a much more open approach.
Yeah.
Because technically speaking, if somebody goes for termination in the UK now, they're sidestepping the local law,
Yeah.
which is not a very comfortable place for them to be.
And that's an important point, because the other thing that amending our law does is it provides legal certainty for our clinicians in Jersey when they refer to the UK. And that's particularly important because at the moment in our law in Jersey, we have a 24-week limit for termination in the case of serious fetal anomaly. So if a serious fetal anomaly in Jersey was to be found at the moment, and the woman was post 24 weeks, and the clinician wished to refer the woman to the UK, where she could, in their law, have a post 24-week termination on the grounds of a serious fetal anomaly. There is an area of complexity for our clinicians. Amending the law resolves that complexity.
Can I just follow up on the money point? Accepting your point that budgets have to be constrained and you want a reasonably consistent policy, does it trouble you at all that access to pregnancy services is essentially therefore a financially constrained, and that some people will be unable to access pregnancy services because they have to go off island?
Can I say I did earlier on take off any costs for anyone under 18 and anyone in full-time education under 21 and anyone on income support and anyone who has been had raped or has had incest. So that was, but we really need some money in the service because we absolutely need a counsellor who's trauma trained so the payments are going towards the counsellor.
So there's ring-fenced spending of that money to help within the service in the island.
I think you can describe it as a partial constraint in specific areas. So it's not a broad constraint.
Okay.
Can I ask a follow-up? Do you have ministerial discretion if there's somebody who, so I understand if you're under 18, if you're accessing income support, some of the other criteria. What about if you don't meet those criteria and yet you cannot afford to access the service? Do you have discretion?
I think that the clinicians have discretion.
So at the moment, the fees associated with the termination of pregnancy are non-statutory fees. They're all done as a matter of policy. Under the new law, we propose that they're statutory fees. That's really important because it provides for full transparency for everybody. And in bringing forward the order that provides for the fees, we will ensure that there is a degree of clinical judgment because there are always exceptional cases that arise in relation to matters related to termination. I think the other
Sorry, can I just clarify the examples that the Assistant Minister gave?
They will still exist. Exactly. They will translate. We will absolutely. Yes.
Thank you. Sorry.
I think that the other thing just to always think about when you're talking about the costs associated with termination is in Jersey, contraception is a paid-for service. If termination was to be made a free service and contraception was a paid-for service, you run the risk of creating some kind of perverse incentives to use early stage termination as a form of contraception. So if we were to think about termination being a wholly free service, we would need to think about in the round what also happens with access to contraception as well, from a public policy perspective.
That's helpful. Deputy Balash, I'm just going to jump ahead. I'm going to leapfrog over one of your questions because this touches on. So there was something in the report that mentioned providing termination services free of charge could result in unintended consequences. Is that what was meant by the unintended consequences?
That would be our concern.
Yes.
So there are, and I am not necessarily talking about experience in Jersey, but there is quite a lot of information and research that shows that in lots of jurisdictions there are a core group of, very small, but core group of women who use termination as a form of contraception, partly because of barriers to accessing contraception. So we would not want to do anything that fed into that. We would want to look at it in the round.
The obvious way would
Yeah,
be to,
yeah.
to
Exactly.
make contraception more easily
So
accessible.
That's something
that is a future policy decision.
That's something we have to work. It's one of our things that we need
Is that
to.
work stream still ongoing, the
It is.
contraception?
It is. But we've been. I'm ashamed to say that that's one that the only thing I think that I've fallen down on, that we haven't finished that yet because it's quite complex.
Okay.
So it's ongoing, but I'm really apologise that it's not finished.
Okay, so just to draw this together, thank you. So there's an understanding that it's not best practice kind of clinically to have free to access termination services and alongside paid for contraception services. And there is a political will, please, I would like Minister and Assistant Minister to give their views on this. Is the intention, the policy direction as much as you can, given the short time, to provide free to access contraception as well as free to access termination? Is that the long-term plan?
I think we'd have to look at that very carefully. At the moment, contraception is free for under 23s, but it's something that we would have to do all the calculations on. I mean, ideally, in the ideal world, you provide everything for free, but we cannot do that.
Well, we're not talking about everything. So in terms of contraception, I mean, is there what does the evidence say about what is best practice in terms of those services being funded or not?
So, if you look at contraception services, the UK provides free contraception to all people of all ages. The UK is an outlier in Europe. Most other European countries only provide free contraception to all people below certain age limits. Those age limits vary, but they are usually somewhere between about 21 and 30. And interestingly enough, if you look at the UK, which does provide free contraception, because there are all sorts of pulls and drivers around reproductive health, but if you look at the UK, which does provide free contraception to everybody, the UK at the same time has one of the higher rates of termination of pregnancy than some of the other jurisdictions in which contraception is paid for. And that is because reproductive decisions are not solely based on contraception. They are based on a whole load of other factors and drivers. So as I'm sure you will recall, in the 1980s, there was a big concern in the UK about pregnancy for housing amongst teenagers. It is not that there's nothing straightforward and simple in what is the best public policy around access to these services.
Okay, so would you expect that whoever is the next minister is going to be making those decisions quite early on?
One would hope they'd look at it.
As-
One can't preempt what they might decide, but one would hope that they carry on where we're trying to
Work
actually.
that we're trying to do.
And the women's health strategy will have to address this issue for the future ministers
Okay.
to make decisions around.
Can I just briefly get a view from you, Minister? If you are the next minister, what is your view around funded contraception and funded termination services?
To be honest with you, I haven't looked at it in great detail, but in principle, I would be in favour of it in targeted areas where it's likely to produce a positive result, but not necessarily look at it as a blanket affair. In the same way as I wouldn't look at anything in blanket terms. I think it needs to be looked through very carefully, and it needs to be targeted.
Okay,
That would
thank
be
you.
just an overview of the situation.
Okay, Deputy Balash, would you like to take question 7 now?
Training Minister, could you just tell us what is the policy so far as giving counselling to women who are contemplating a termination is?
You'd probably be closer.
Yes,
to that.
there will be a counsellor who will be there, but it's not going to be mandatory that they have to see the counsellor, but they will be offered a counselling service if they would like to have that.
And would this involve trauma-informed
It
counselling?
will, it does. The person we got is excellent and trained and trauma-informed. Because I think it does make a real impact. You know, it's not something to be taken lightly.
And you also have question 9.
Sorry, which is
9.
9. I'm sorry. Yes, the anti-abortion group Centre for Bioethical Reform were in the island recently and have produced a report for their website. Do you see any risk to healthcare professionals resulting from the activities of this group or others like them?
I think it's a very, very sensitive subject. There is a possibility of having a safety zone around the clinic at the hospital. I mean, hopefully, I don't think much will change because I do understand that the anti-abortion lobby who don't agree with it at all, and I understand that for their point of view. But we're just trying to offer a compassionate, kind, efficient, safe service for islanders.
Could I just check? Was your question, sorry, related to concern about the well-being of the people delivering the service in terms of being attacked?
I think the Assistant Minister has answered the question I put.
Sorry,
Yes.
I just wondered if.
Did you want to add anything, Minister?
No, I was just concerned that we hadn't answered it fully.
And it's always hard because there are always two sides to every story, aren't there?
Could you give us a bit more information about the safe access zones
I
and
think
how it
it's-
would work?
I think it's just an area around a clinic that is a safe zone and no one can be attacked in any way around it.
So the draft termination of pregnancy law provides for a regulation making power to introduce safe access zones. So assuming the draft law is adopted, what we will do is we will bring the regulations to the States Assembly, and the regulations will be enable the States Assembly to determine what actions are not lawful in a safe access zone. So that might be harassment, it might be shouting, it might be obstructing people, a whole range of particular activities that may be unlawful in a safe access zone. There may be some activities that the regulations explicitly say are lawful, for example, silent prayer. Those are decisions that need to be made as part of the policy development process and decisions to be made by the Assembly. The regulations will then have within them a power for the Minister by order to designate the actual area that is a safe access zone. And the reason why they will be designated by order is that it may well be that in Jersey in future we get early termination clinics, so kind of pre-10-week termination services being delivered by providers other than within the hospital. So if, for example, a GP service was to run a termination clinic we may then use that order-making power to create a safe access zone around the GP surgery. So we've tried to design it to be as flexible as possible, depending on what happens in the future.
But up until now, it's just been a very quiet service.
Yeah.
And this hasn't had to come into play.
But will that process automatically happen if this is approved, or will ministers wait until there is a need for it, or do you intend to have it in place from immediately?
So we will be developing safe access zone regulations under the assisted dying law in any event if the assisted dying law is adopted. So there will obviously need to be a decision made by the next Minister for Health and Social Services as to whether or not the Minister wishes those regulations to be presented to the States Assembly with regard to termination clinics or not.
So that's not a given in this proposal that's currently before
No,
the
it's
States
simply
that will actually happen.
Yes,
Yeah, okay.
but of course any member of the Assembly could take a proposition asking that the Minister brings forward those regulations.
So questions around how they would be monitored will come later.
Yes,
Right.
yes.
Yeah,
Fine.
but it's not. We've been running this service. When did we start?
When the law was
Whenever
amended.
the law was,
Yeah,
the termination law started.
It's the 90s, isn't it?
It would be a rather sad
99.
state of affairs
If
if
we
we
had
had
to,
one.
yeah, I think it would be really. I mean, I think it's, Jersey's a kind place.
Thank you. In terms of the safe access zones, and I believe this is possible looking at the wording of the law, is it possible for an order to be made to create a safe access zone around a place that isn't necessarily where the service is being delivered? For example, perhaps a girls' school where if protesters target, say, an all-girls school or any other locations, will that be able to be covered by the...
I would assume we need to take advice on that. I don't know what the law does or doesn't permit.
May I come back to you on that one?
Yeah.
Okay, yeah, I think it looks like it does.
Formal
but-
legal advice
yeah,
on
if you
that, just to
thank you.
make sure.
Okay, thank you. And we're going to... Does anyone have any further questions on the termination of pregnancy legislation? No, okay, we may follow up certainly on that one, maybe on a couple of the other areas as well. We're going to move on to another area of women's health, IVF funding.
Thank you. And perhaps we could start, ministers, with the underspend from last year. And I know we've spoken in the Assembly about the request to have it returned, as it were, and that request was put in. Are you able to provide us an update on that,
Just
please?
wonder, I think it might be useful if Hazel were to join us at the table, because Hazel's carried out quite a lot of work in recent times.
Hazel Cunningham, Director of Finance for Healthcare Jersey.
Welcome, thank you.
Thank you very much.
So yes, just on the 200 or approximately £280,000 underspend from the IVF budget last year, and we've heard from ministers in the Assembly that requests had been made to revisit that decision about the underspend. Is there an update?
My understanding is that we're not in a position to have that money back, but as I say, you're in a better position than I am, Hazel, to explain the reasoning for that.
Yes,
if you would.
thank you. So in relation to 2025 financial year, the IVF funding was provided as growth monies, and there are very clear guidelines under the Public Finance Manual. At any underspend, it has to be handed back at the end of the financial year. It's not possible to carry that money over into the next financial year. And that is the process that has been conducted through the year-end process. But also the Public Finance Manual sets out how underspends are treated from one year to the next. So there is not a process for carrying forward in annual budgeting processes that carry forward. So there isn't a process under the Public Finance Manual.
But there is a process where ministers want to make the case to have that money, and they have to present a business plan, I understand it, and have that discussion with Treasury Minister or whoever assesses it. Has that process happened?
We do have an anomaly and an anomaly here, and I think it's one that we need to address. I'm happy for
So
Andy
since
to...
I met with Deputy Stevenson and the Tiny Seeds Chloe, last week, we had confirmation that although the reported 2025 underspend was almost 270,000, the 225 budget did not include HCJ staff costs. The Minister's amendment for P2024 stated that IVS services costs would be up to 620,000, clinic costs and HCJ staff costs, but the HCJ staff costs were not factored into the 2025 government budget. So as we did not know the demand or staffing impact of 2025, HCJ proceeded with known risk, read the staffing impact. But failure to include staff in the 2025 budget has resulted in ARU staff working to meet the IVF demand, and this has had an impact on general gynae, recurrent miscarriage, other services that are carried out there.
I think it might be worth, I don't know, Hazel, if you've got the number, the estimated number for 2025 for the HCJ staff costs that relate to IVF, because this is interesting, because what you'll find, and I say Hazel will come up with a figure, but given that we gave money back to the Treasury, we actually had to take the money for the staff costs out of an existing budget for which it was not budgeted. So it actually had a negative impact on our overall budget. But I'll leave Hazel to provide the details.
So if we were to look at it again, retrospectively, we would be looking at something around about £200,000 for an annual cost for a full year effect.
And the the decision of the Assembly was a growth decision to 620 growth. How many new staff have been taken on to cope with that work?
So as the Assistant Minister has already explained, so the staff were the ARU staff that supported the IVF service, which meant they were being used by both sets of clinics. So effectively some of the duties for ARU would not have been undertaken while they were doing the IVF clinic.
So they were existing staff?
In that case, because there wasn't additional funding provided for the staff. So this is where, when we're looking forward into 2026, we need to take into account that additional staff would be required to make sure this service is fully operational and effective on a full year basis. So I think we can learn from this in terms of the 2025 experience. It was setting up a new service. And in order to put that service in place, there was a number of months in order to make sure that all of the service requirements, the overseas clinics, etc., were in place. And therefore, what they were also doing was using existing staff. But if we want to provide a full service in 26, we will need to accommodate the additional staff costs within the budget. Okay.
So
I'm just gonna, because I'm
confused.
It's relatively straightforward, I think.
I'm not confused, but I don't know how to say this. I'm a little bit worried that staff that already existed, that were providing a service, that are now providing a funded service. So people were paying privately, but now it's moved to public. There's no new staff costs, but there was growth money allocated. Effectively, in my mind, it feels like that department is having its budget that existed before, plus its growth funding, now eroded effectively.
Not at all. There are no staff in the hospital twiddling their thumbs, and when we have to redeploy people, it creates a void or a lack of work that can take place. That's the actual work that they would have done.
So you've redeployed people to cope with it?
No, we've actually used existing people to do work on IVF that wouldn't otherwise have been doing it, because without the funding, the IVF wouldn't have increased to the extent that it has. So what we have to do is to make sure that we don't carry on putting that work at detriment and not doing other work in order to do this work. So that the money will be required to beef up the staffing to make sure that we can do the work that we were doing and the additional work. It's relatively straightforward.
I will come to you. So I'm just trying to understand. So before this change in policy, if there were the same number of people accessing paid for IVF and you just made it funded, you wouldn't have needed any extra staff, would you? It was my understanding that the funding was simply to stop people having to pay for the service, that it wasn't necessarily an increase.
I think
I think it also makes,
cycles.
it makes IVF available to people who would not otherwise not have had the money to have IVF.
So has there been
So
an increase in, I don't know what the terminology would be, the number of cycles or the amount of...
my understanding is that there has, and
Yes.
as there would be, because if people can't afford IVF, I thought the whole principle behind this was to make IVF available to people who would not otherwise be able to afford it. As a consequence, your numbers go up, and as I say, you can't then cope with extra numbers without taking into account the entire costing situation.
So I think we've had another 63 IVF cycles this year, which the government have provided.
Over and above what number?
Yes.
What's
Well,
the kind of
I mean,
standard business as usual?
We can check that figure and we can get it back to you. There has been an increase in the number of patients as a direct result of funded IVF. I don't have those figures available now. We can find them out and give
I
them
may
to
be
you.
missing something very obvious here, for which apologies, but wasn't the growth bid designed partly to pay for new people to come in and do that extra work? And in a way, by not employing those extra people, you just deferred for a year a decision that was inevitable anyway. Why weren't people employed straight away?
Because we weren't at the stage. I think I remember making the statement in the Assembly that we were doing this almost on an experimental basis, and it didn't reflect the work we'd have to do. We're now able to quantify what that is, because we've seen the number of extra IVF treatments that we've got. And we've been able to. I think we've been able to reasonably accurately calculate the amount of staff resource that's required. And at the end of year one, we're now in a position to give you a relatively balanced view of what those cost effects are. And what we're saying is that we have to address those, because we can't carry on ad infinitum, either subsidising it from elsewhere or stopping doing the work that those people would otherwise have been doing. So it does need to be staffed appropriately going forward.
So
and we've now got a picture of what that looks like.
So we will need, I think, £268,000 for staff to run the IVF service for 2026. And if the predictions are right, we may run out of money in November. And if that is the case, if we go over the 620 in November, we may have to stop the service then and get them to wait until January 2027 before they can have their IVF
The
treatment.
danger here is if we don't take a disciplined approach to this, it'll be the same as we're going to get in every other department, and we'll be back to having a large deficit, and everybody was saying health is overspending. But I think what we're trying to get into the system now is a more disciplined approach to funding and a more open approach to it, so we can actually make clear what's going on to people and say this is the effect. If people want more money for IVF on top of that because there's a disappointment factor, so be it. But that has to come from somewhere, and I would suggest it doesn't come from our base budget, because the amount of times our base budget gets eroded almost accidentally by people introducing new things. We need to have clarity on that going forward.
But you consciously chose not to spend all the growth money because you decided that you wanted to work out how much would be required first, in terms of how many extra people would be required to meet that service. And then you would start spending up to the limit.
Yeah, as I say, it wasn't a precise science. So you've got to bear in mind we're sort of almost moving into a vacuum and establishing a service, evaluating what that service looks like in the first year, and coming back and giving you an open, honest appraisal of what that looks like, and saying these are the measures we need to take going forward to make sure that we balance our books to the best extent that we can.
I think while we've got Hazel here, are we able to just drill into that 268,000? What staff does that involve at working at what level?
So you'd have two nurse grades, so they'd be half FTEs, so 2 half FTEs, half admin support, and then you'd have consultant time, a number of consultant PAs and middle grade doctor.
And then a counsellor and a middle grade.
The middle grade, yes. Yeah. So, and as the assistant minister said, so part of that would be counselling as well.
So that all added together, ignoring the grades, how many FTE
So you've got, I think it's 7 PAs from a level perspective, half an FTE of a nurse grade at 6, half a nurse grade at 5, and half an admin, which is a relatively low, so it's a grade 6 roughly.
There's pronatal policies.
And then
there,
and
which
there's
probably
also
are
the
pretty good.
IT as well.
Pretty well assure a bet as you get, isn't that?
Yeah, there's admin and IT costs as well thrown in.
So those
And
are
the ARU budget, aside from the 620,000, do we have the figure for what it was before and what it is
I
going
don't
forward?
have the
You don't have it.
figures
Is that
to hand,
something we
so I
could have?
Yeah, so we can
Thank
share
you.
that with you, so.
Thank you very much. I've completely left the
Shall I go?
left the thing. Yeah, please.
Okay. So currently single people wanting to start a family can't access the IVF funding. I think this has been touched on before, Assistant Minister. What are your plans to change this?
Well, unfortunately, although I was, we're up to looking at the criteria again, but we can't do anything at the moment because we will have to see how this pans out going forward. If the by any chance the demand goes right down and we just have 2 couples coming forward, then of course we'll look at the criteria, but we'll have to just monitor it quarter by quarter.
What is the rationale for excluding single
I
people?
believe that Deputy Stevenson's original proposition related to couples. So that was why,
Yes,
I think you said it was a couples, wasn't it?
Fair to say that with an unlimited budget, you could do all manner of good things. But if I have a long list of other requirements that urgently require money, so it's a difficult one.
It's just an interesting one, isn't it? That if say you're a woman who wants to have a baby, that if you don't have a partner, that might be a reason why you need IVF.
That was the original proposition that we stuck to.
It doesn't mean you can't do other
So
stuff.
setting that aside.
We just have to look at the figures.
Yeah.
At the moment, we can't do anything.
Given the birth rate is so low, have you done any work to establish whether there would be women, for example, that would like to access this service where it's funded?
We haven't done any. I don't think we've done any work.
So we haven't done any specific work. I mean, we can do population projections to try to estimate the numbers of single women in Jersey who are of childbearing age. So there are some kind of rough and ready calculations that we can do on a population basis. But obviously that would presume that those single women want to become parents. So it's a relatively meaningless figure. There is very mixed evidence from other jurisdictions that the provision of IVF to single women has any real material impact on the birth rate in those jurisdictions, and there is conflicting evidence about whether or not, if you want to incentivise increases in birth rates, investment in IVF is the most cost-effective way to do that, versus, for example, investment in childcare.
Okay, Minister, could you reflect on the potential risk of, to women, particularly exposure to domestic violence, given the fact that women can only access that funded IVF if they're in a relationship and in the context of the Vaughan report? Is that something you could go away and reflect on and think about?
And also, I think
policy?
I haven't discounted. We need to think also about gay men.
I'm going to come on to that in another question, but I'll let Deputy Stevenson, if she's gathered her thoughts, carry on with.
So I think probably before I ask the next question, there's not going to be a review of the criteria.
Not at the current time,
Not at the current
because
time,
we
fine.
changed them at the beginning of October.
Yeah.
And although if there had been an underspend, that would have been a very different scenario. But because we now need to put in the staff costs, we have to just run for several, at least 2 quarters, I'd have thought, before we can review.
The current guidance has that couples earning under a combined income of £82,300 currently qualify for 3 rounds of IVF funding. That threshold's based on 2021 mean earnings. And obviously we're a few years on from that, and average incomes have risen. Are there any plans to revisit that figure?
Well, we won't be doing anything until the figures have come out. But then we will.
Which figures?
The 82,000 that you just mentioned. But we need the figures for how many couples are going and what the costs of the service are before we can change anything.
And when do you expect to have that full picture that you want?
Probably, do you think in
So
quarter two?
we have a commitment to review everything that happens with IVF, a kind of root and branch review on a quarterly basis. So next month we will sit down, and one of the things that we will look at relates to whether or not those income thresholds should change to track the current averages around earning thresholds, or whether or not we need to maintain them as we are because the budget is squeaky tight.
So it is on the agenda.
It is on the agenda. It hasn't been forgotten. Yeah. But given that, given where we currently stand at the moment, with regard to a forecast budget for 2026, assuming we have the same footfall through the service, we end up with a deficit budget at this point in time. Recognising that the income thresholds have changed, we are not proposing any changes. But when we do our quarterly review and we look at what activity has happened in January, February and March of this year, and whether or not there's any decline in activity, which may suggest we've got some flex in the budget, that will be one of the very first things we look at.
Okay, thank you very much.
Thank you. A question around same-sex female couples, and we've had many discussions around this, Assistant Minister, and I'm really pleased that you did extend the eligibility criteria in autumn last year to include same-sex female couples. I wanted to ask about the reciprocal IVF. Again, in a response to a written question, you said that it was possible to apply the same funding amount to reciprocal IVF.
It is,
but
then they'd have to make up the deficit.
Sure, thank you. And so you mentioned in your response that donor eggs and sperm are not funded. Are you finding, so not just for same-sex couples, but for all couples, because they're not funded at all, are they, for any of the couples?
No, they're not. The reason is that it has to be the choice of the person who's going to be the parent, who they choose for their donor.
Are you finding that any couples, even with the bulk of the funding offered, are still not able to afford to access because of the cost of those elements?
I think that's really important, that you choose your own, because then it is your decision. Mm-hmm. It cannot be, we cannot provide that.
So no plans to change that element of it. Okay, thank you. And in terms of same-sex male couples, are there any plans underway to enable those couples to have access to any of the services?
As I keep saying, unfortunately, we can't. They're obviously. We can't do that at the moment.
I think it's safe to say if you broaden the criteria, the more you broaden the criteria, the sooner you have to stop providing the service in the year and wait till you get to, so you're building up a waiting list. That's the sad truth of it.
Yeah, obviously we've asked about several different areas and different ways that the criteria could be expanded. If you could consider those when you've got all the information that you need to have.
And I was very grateful for the conversation I had with Tiny Seeds and Deputy Stevenson.
Sure. Okay, do you think that we've covered that? Yeah, okay. Thank you for that. We're already nearly halfway through, so we might need to get more of a gallop, I think.
We might need to get Stone back.
Yes, so we're going to ask about home birth next. So if you need to do any reshuffling, please do. Thank you. Thank you. You're taking this one, aren't you? Yeah. Hello.
Hello. Thank you. Do you want to introduce yourself?
Change lead for HCJ. Acting on behalf of Tabitha Darman, who is the chief nurse with responsibility for maternity care.
Okay. Obviously, the home birth service was suspended in October 2024, and then it was further announced that there would be a review following incidents in the UK. Can you update us on what the situation is with regard to that review and the future of home birth services in Jersey?
Very much so. I think it is recognising the underarching objective of any home birth service is ultimately the safety and well-being of both maternal and neonates. That's our overarching objective. In addition, it's that ability to provide a consistent service. We know across the UK, services that switch on and switch off are again detrimental to both the health and well-being and safety of families. So those are two key overriding parameters. Within the UK, within November, that Prevention Future Death Order that came out following the tragic maternal and child death in Manchester was very clear in 6 failings. Those 6 failings have resulted in the UK bringing together all midwifery and healthcare professionals to develop clear guidelines, evidence-based practice for the provision of a home birth delivery. Jersey has been involved with that, working alongside our colleagues in the UK. The review of that Prevention Future Death was due to make a report in January. That has now been withheld and did not come out on the 6th of January as was required. Alongside that, Jersey has currently, in line with what I am aware that Ms Ros-Bullen-Bell and Tabitha Darman has brought previously, work relating to competencies, work looking at rostering, work looking towards governance framework, and that multidisciplinary working is underway to ensure against our own best practice that those standards are in place before a service could be resumed. We are currently awaiting the benchmarked evidence to come from the UK to support those. So the work has been ongoing, and until we have that benchmark evidence to ensure that we are doing what we are doing is in the best interest and safety of all maternity and neonatal women across Jersey, that's what we're waiting for currently.
Can I just probe a little bit on the relevance of the UK examples to Jersey? The particular case that happened in Manchester was a catalogue of failings. And why was it determined that Jersey had to act in relation to that? I mean, was there any evidence that any of those failings were in play in Jersey?
I think what was very clear from the 6 areas that were raised within that report, and they talked about clear, defined national standards. What was the requirement for risk assessment for a home birth service? It also identified there were not clearly defined staffing models. It also identified there were no competencies available and the lack of robust governance arrangements. If we take ourselves back to November 2024, when the service was paused in Jersey, because we knew at that time we had a lack of staff with those clinical competencies. I think it's fair to say we have a super team of midwives, very, very much committed to the safe and well-being of our women and our children in Jersey. But that ability to provide that service consistently was not available in November 2024 when we made that decision. Those decisions, if you actually look, they mirror, when we made that decision, they almost mirror those members of the Prevention Future Death Order. We were concerned about staffing. We were concerned about risk assessments, and we were concerned about protocols. So we made that informed decision, and that was made informed. It was made against clear evidence. Heaven forbid we should be validated for making that, but clearly our Prevention Future Death Order, and if anybody has read the case, it is a very tragic read. A young mum and her baby are not with us. They should be with us here today. And I'm confident with the service we have in Jersey today that they will still be with us. But we cannot move forward until we are very clear that that evidence base that is coming to us from the UK, we are in line with that. So I think the question you asked, was there were definite synergies with those there, which is almost, heaven forbid one should wish validation for an action, but clearly there was a validation there.
Can I pick up on something? So you mentioned consistency being something that's important and the reason why the service was paused. Can you describe what the inconsistencies were? What did that look like before it was paused?
So inconsistencies, it's generally, the inconsistent will be the availability of staffing.
Right, so the fact that if a home birth goes over a 12-hour shift or whatever, then there might not be another midwife available.
It may be in the beginning of that, because if we actually look at what is happening in the UK currently, when services are being cessated, it will be to the use of lack of staff. It may not just be the lack of staff to undertake the home delivery, but actually if your surrounding maternity units are actually at full capacity and you have all the staff, you do not have enough staff to take them away. So for inconsistency, if you are director of midwifery or head of midwifery, you will be looking at the deliveries we have going on at the unit, that which we know may come in, and also always in the background, because babies don't always come to order. How many babies have we booked for this month? Do we know we can have that? You know, we know at certain times of year we have those peaks and troughs if we look at all evidence, and where will that inflict? So if I know today as director of midwifery, my maternity unit is full, I've got some sick leave coming on this evening, I will not be up to my minimal staffing levels. At that stage, one would be prioritising for the next 12 hours, I will not be able to support a home delivery service. So that's what I talk about consistency of standard.
Okay, and in terms of understanding what islanders and what women want, it's my understanding that the home birth service has always had an element of not being able to be consistently offered for those reasons, and that was understood and accepted by women who were opting into that service. So could you not maintain the safety, that the understandably very high safety threshold, by offering that service, but with a caveat that it might be inconsistent, and that on the day or night or whenever birth is happening, that woman might actually be told, well, the service is not available tonight. But to have some offering where the staff can fulfil it, is that not an option? Would that not be better?
So I think what we have to go back to that first principle, which was outlined in the Prevention of Future Death, to be able to offer that, and that is what some services do currently in the UK. They actually switch on and switch off the maternity service. To be able to undertake that, you need a significant cohort of staff that have those skills. What we know in November 24, we only had a very small cohort of staff. I'm a very old midwife. I was privileged enough to train with a lady called Mary Quank. She's one of the most famous independent midwives in the country. I've undertaken a lot of home deliveries. I know what we're talking about. A lot of our newly qualified midwives do not have that portfolio of experience. When you are working in the community, that level of risk assessment and how you deal in autonomy, you need that level of experience. And I think that is what is key. It was very clear within November 24, we did not have that cohort of midwives. So we didn't have that ability to switch on and switch off that service consistently, because our service should be for all women, not for just those at a certain time.
Can I just wrap it up perhaps by getting some clarity on where we're going with this? You've talked about needing to hear from the UK. What timetable are you working to? What will be the process? Is there going to be a report? Is there going to be an announcement? And if so, who's doing it? What will be the decision-making points, and when do you expect to make them?
So I think there's three, mindful of wrapping up, however, there are three components to this. Irrespective of if the UK make a decision, we will then have to assess, have to start, have they been appropriately trained, do we have enough staff, and where are vacancies? And that's what something with our Director of Midwifery is working currently, and you've heard how we've ensured we have the correct training. But that will be an answer that has to be taken at that moment in time. As I said, the UK was due to make forward, and I think it's the 6th of January. It did not come out. We've been told it's going to be end of February, it may be March. We have not been given a definitive timeline. Then taking that notice into priority, it will come through our normal decision-making process. But until we have had that evidence of what a good service should look like, what are the standards, what are the competencies against which we can benchmark ourselves, it would not be safe to resume that. So I'm sorry, I have not given you a date which is X date. I do apologise for that.
I understand that. My only caveat around all of that was that you're talking about things which have been on the go since November 24. With that review of competencies, all those sorts of things.
I'm sorry, yeah. I do apologise. I can assure you that, Ms. Mollenberg, we have worked extensive. We now have a very, very good training problem. I know as of today, up to 85% of our midwives have that level of skill. We have worked very closely with our ambulance service, making sure that because as I outlined in the Prevention of Future Death report, the ambulance services were identified, working well with our ambulance services to ensure we have the correct paramedic support. But in addition to that, we have the correct pathway. So I wouldn't like Scrutiny to think we're sat there on our laurels waiting for something. This is work that has been ongoing at all times to maintain the safety of our women. And I think something I do have to say, which, we do have a most amazing midwifery-led unit. It's under 3 years old. It was developed with our women in mind. And for, any woman who wants a near home birth experience, I would commend them to talk to Rosalind Bollenbell. It is a super unit. We are a small island, and it does give an amazing experience.
Yeah, and you can take any personal effects in with you, and you can make it as home. I know it's not at home, but it's as close as you possibly could, and it will give you a really, since we've had the privilege of reviewing our maternity unit, we've come ahead in leaps and bounds, and we've gone through all of those criteria that we had to improve.
I'm probably speaking out of turn, but I'm a little.
You are, Minister. Please speak.
Well, yeah, but I don't like to speak out of turn. But I'm a little bit concerned that there's been a consistent pressure about this all the way through, and a pressure for dates. When we have a date for this and a date for that. And I think what's been made very, very clear this afternoon is this has to be and will continue to be driven by safety considerations. And I've got to say, we're now reasonably close to this. There's an awful lot of work that's gone on over a long period of time. And nobody here is going to move off the mark until people like Kathy are able to sit there and say, I'm 100% certain this can go back out in whatever form it goes back out in, and it's safe. And I hope you'll agree that that's really has to be the priority rather than fixed dates. It has to be, safety has to be the principal consideration. And I do worry that there does feel, I'm sitting here and I've felt every time this has been mentioned that there has been a sort of an underlying pressure to provide dates.
Feeling that that safety, there's never going to be 100% safety around childbirth. There are judgments to be made, and the sense has sometimes come back, I think, to me certainly, about a reluctance to.
No, not at all.
do
I have
that.
to say,
So that's why those questions are tough, but I hope fair.
clarify, no reluctance at all. But as I say, I think nothing's going to ever be 100%. But I'd rather rely on the judgment of people that have got a lifetime of experience than us as politicians sort of trying to give you a date just to tick a box. So I hope you don't mind it. I think it's an important point to make.
And I think when Jersey's making cautious decisions, whereas other people may be making decisions in a different way as well, it's a very legitimate thing for us to ask those questions about why we're following that route when other places are continuing with their home birth service.
But we just want we don't want the headlines that they had in Manchester.
We don't want the tragedy. That's really the headlines follow the tragedy.
Yeah,
we don't want the
tragedy.
tragedy.
I mean, ultimately, we are asking questions of you, Minister, and you're obviously
And
on
that's
behalf of members of the
Absolutely,
public.
I get that. I get that too. I get that as well. But I'm just trying to provide a little bit of balance.
I understand. And one final one, just for any avoidance of doubt, is the aim to reinstate the home birth service once all of the training reports, etc., once all of that is covered? Is the aim to reinstate a safe home birth service in Jersey?
I think the reinstatement of a safe home birth service will be a decision for a decision making process, but it is not. And the intention is not to reinstate it.
Sorry, the intention is or isn't to reinstate?
The intention is when we have those facilities that we have a safe and effective and responsive service, then the decision will be then made whether or not to reinstate that decision.
Okay, and who makes that decision?
I will now affect that I am unaware of Jersey health making process. And I do apologise, and I do apologise most sincerely to my chief officer because I am unaware of that. So I look at the minister.
Is it ultimately the minister who makes that decision?
It has to
No, I think it would be clinically. It would be a clinically led
it has
decision.
it has to be a clinical decision.
I know what it would be in the UK, but I would wish to insult Jersey. I do apologise for my lack of knowledge.
No, thank you, and thank you for the evidence that you've given. You clearly have a lot of expertise in this area, so thank you. Okay, so the aim is to clinically have all the facilities and training
Almost
available so that
definitely, yes.
a safe an efficient home birth service can be run where the decision makers
Almost
wish it to be.
definitely. The answer is yes.
Okay.
I
A Minister, is that your wish
Yeah,
to reinstate
it is, but it has to be said that if you came to the end of the process and you said that you reviewed everything and everything was perfectly safe insofar as the service that you offer, but it would need extra resources and extra people to be on standby to have a home birth service, that's the point at which we could come back and say, it's all been reviewed and on balance, we can provide the service that we've got and no more. And that to provide, and at that point, I should imagine you could then quantify what it would take to introduce a service. But it's a process that has to be undergone, and it's at that point in time that we'd be able to come back with the decision that either it can be safely reintroduced, or in order to safely introduce it, it will require X amount of extra resources.
Okay.
So I hope that gives you clarity, because I know you've been looking for clarity, and we tried our best to provide that.
I presume that's where a clinical decision then becomes a political decision. Is that?
Absolutely. The clinical comes first, and
Yeah.
the political has to follow as to what then does the public want, how much are they prepared, how much tax do we charge people, and where do we put our priorities. So, but it may well be that once the analysis is done, that it does allow for the service to reopen. But those decisions will be made on a clinical
And
basis.
if I may, the Prevention of Future Deaths review that is currently underway, that very much is looking at resources required and staffing levels. So again, when we're looking at a funding, it will be staffing resource that will inform, and that is one of the clear criteria of this review, because currently in the UK there is very clear guidance on intrapartum and postnatal care. We do not have that guidance or governance framework for home delivery.
And there is desire to get this done as quickly as possible, because the good people here have got so much else to get on with once they've done that. So nobody's dragging their heels.
Yeah, very busy team. Thank you. We're going to move on to the section on endometriosis. Can I just ask that where there are any steps forward or anything has progressed in this area, that you could keep us updated as and when, we'd be grateful. Thank you. Deputy Balash is going to ask about the endometriosis clinic.
Minister, can I just say that we're delighted to see your Chief Officer here for the first time, and we almost got him to speak just now.
Keep going.
On endometriosis, we understand the clinic is now established and operational and has begun seeing patients. And I wonder if I could ask how many patients the clinic has supported since its opening.
I don't know, we can say, I don't think we can, I'm afraid I can't say the number that we've supported.
So I don't know if Claire has.
So I haven't come with that number.
No,
today,
but
so
we
I haven't
are,
supplied it, yeah.
we have 2 clinics running. We've got a clinic in the General Hospital and a clinic at the Inikene. And they are looking after patients.
And can you say what specific services they offer to
I
patients?
think they are specialist clinics, so that for women who've been suffering very badly over a period of years, they are being clinically looked after in those 2 clinics.
And is it possible to say how it's performing in terms of outcomes?
I think the people that have come back to us have said thank you very much, and because it's I think it's just a horrible disease, and people sometimes suffer for years and years and years without having a diagnosis.
It's certainly receiving a lot more attention than it used to. Strangely enough, whilst we're bringing the threads together, it involves our ministerial team quite a lot, because I think all 4 of us ended up attending a meeting that was held by somebody that had suffered for a long time with endometriosis. We had a long chat afterwards. We're well underway to establish a proper working group for endometriosis that takes into account everything from GPs to the end of the service. We've got one specialist, as you know, without naming names, who's involved and very keen for this to happen. And we've had a number of specific cases that have been ongoing for a long period of time, now being fast-tracked to comprehensive treatment.
And then we've got a link to specialist UK endometriosis clinics, so they can have conversations, MDT conversations and treatment, tertiary referrals.
Yeah, discussions are underway to make commercial arrangements for that to be a formal process going forward. But that we have had some, whilst they haven't reached the end of the process, some successes in getting people with severe endometriosis finally recognised, and the complexity of the condition being recognised and being dealt with in a much more comprehensive, all-encompassing manner, rather than dealing with single issues one at a time. They're being properly assessed in the overall and being sent for comprehensive treatment, and that's something relatively new. It's something that we're very, very keen to maintain. Because when
we're really delighted to have set this up for the women of Jersey.
Important.
Bearing in mind that I think I'm right in saying 1 in 10 women live with this condition. Are you satisfied that there is sufficient investment or in the department to ensure that the clinic meets future demand?
The answer is no, we're not. But like everything else, we have to look at priorities. But this is work ongoing. We're looking to establish a comprehensive service where we can penetrate the population, get people to recognise very quickly, work with GPs so that they can recognise it more quickly. So this is the first building blocks for something that's going to take some time. As with so many things in medicine, I think once we've got the investment in place to get the network running, the fact that we can then identify and treat people earlier and treat them better will have an overarching positive financial effect. Because I know a number of people who've been off work for a long time. You lose that productivity, you have all the misery that goes with it. You have one appointment after another where the whole process goes nowhere. So if you can fast track the process and make it efficient and get people back to work and having a happy life again, I think this would be self-funding. But we get back to the point, to the raw fact that you need that initial investment to get that underway, as you do with so many areas of health. Well, we started to solve that problem by getting a chunk of extra money for preventative work. And that's where emphasis, whoever sits in this seat going forward, is going to have to make sure that we really put some focus on putting money into preventative work.
So has there been any additional resources put into the endometriosis clinic?
I think we're having to do everything with the existing resources, because we came into a 2026 budget which had been sort of prepared, and as you can make some fine-tuning decisions, but once you're into a prefix budget, you've got very little wiggle room, haven't you?
But we have now got a full complement of consultants in obs and gynae.
Okay. Has there been any of the budget from the assisted reproduction unit that has helped to facilitate this work? Because there is a crossover of consultants, isn't there?
You'll need to come to the table if you want to contribute.
Thank you. Hi, Claire Thompson, Chief Operating Officer for Acute Services. So to help explain, as the Minister was just describing, we are now in a great place in ONG, Obs and Gynae. So we've had 3 years of having 3 or more vacancies, which we were able to onboard all of those consultants who brought a range of specialist knowledge and experience within Obs and Gynae. I think at the last Scrutiny meeting you met Professor Enda McVeigh, who's obviously very experienced in endometriosis and has written extensively on the subject, and actually he's been key in leading the services. As part of our annual job planning approach, what we're able to do, particularly now we're under less pressure across the whole of obstetrics and gynaecology, is apportion Enda's time to providing this activity. Initial endometriosis clinics were run historically by our other gynaecologists, who obviously now we're able to put to the specialisms within the service that they more enjoy and have those specialist skills such as fetal medicine and actually termination of pregnancy, and utilise then Enda's expertise in time in formalising these clinics. Deputy Howell was describing how we've managed to have an MDT process. So as you know, women often affected with this disease have need expertise outside of gynecology, so general surgery, urology, and ENDA has led putting in those multidisciplinary clinics that allows input from our specialist surgeons and doctors on island, but now with this more regular referral to Southampton for those more complex cases and surgery that we wouldn't be able to perform on island, and we're continuing to look at other tertiary centres to complement that.
Thank you very much. So ENDA is also the specialist consultant for assisted reproduction and IVF.
Yes.
So by focusing, I think what I was trying to get at is the questioning before about the money and the cost for staff
Is your money
costs.
being spent elsewhere?
That's the very question,
No,
Minister.
the answer's no.
So that's absolutely not the case that's
Okay,
happening
so
here.
we wouldn't be lying to you about how your money's
It's not a suggestion of lying. I'm trying to work out how the budget's.
No.
Yeah.
That's, I think everybody's playing with a straight bat.
So if I may, most consultant contracts are a minimum of 10 PAs, a PA being a unit of time, a morning or an afternoon. Obviously, we choose then how to deploy consultants' time. So in the morning, they might be in one clinic. In an afternoon, they might be in theatre. So across a consultant's job plan, you'll see them doing a variety of activities, but also they can be a variety of specialisms, for example, ARU, plus then some time on endometriosis within those units of times across the week. So we'd expect to see those dedicated clinics looking at different things. For example, you could have an orthopaedic consultant who was spending time on lower limb in the morning and then other areas of orthopaedics such as trauma on the afternoon. So it's all around the job planning. So hopefully.
And is that just because I think we have talked in previous hearings about having it's the challenge in a small place about having single consultants responsible for multiple areas. Does someone like ENDA doing a lot more work on endometriosis have an impact on waiting times at the assisted reproduction unit, for example?
I'd have to examine that and look, in terms of the time he was spending before, but I don't think we've significantly cut into the time because he wasn't full-time in all of those areas prior.
Great, thank you very much.
Okay, thank you. And I think in previous hearings, we've talked about this kind of severity levels of this condition and that the clinic is primarily focused on the more severe cases. But if we look at Deputy Bellish quoted 1 in 10 women, so that's around 5,000 women that suffer from this condition. What kind of numbers are you treating in the clinic, just to get an idea of where that is?
Sorry, I haven't come with that data today, but I'm really happy to get that and share about, since we've had the clinics in running, how many.
Yes, sorry, you were asked that question already. Could we get that data, and could we have alongside it an understanding of the kind of the severity and the actual impact of the condition alongside it? Thank you. And I also would like to understand that if those services were to be expanded to include some of the kind of middle to lower severity, I'm sorry, I don't know the clinical terms for it, how much would that cost? And if that work is being looked at, I think we'd like to understand whether that is going to be bid for in the next budget, or if there's more preparatory work that needs to be done in the longer term.
Yeah, sure.
I think the Assistant Minister wants to speak. You'll need to come back to the table. Is there anyone that isn't? I think perhaps there's planning needs to. We need to get a bigger table, don't we?
No, it was just to say that I think we are hoping that the GPs will, start the process.
Right, okay.
And so it's only if you're not getting any response from what your GP is able to do for you that you need to be referred in.
And is that a part of the negotiations around subsidising GP fees? Are they required to provide a specific standard of care in return for those subsidies?
I think we're just hoping that some GPs will become specialists in this area because they'll have a special interest in gynecology and endometriosis.
Is there a way to be more certain about that? Or to plan for it?
As I say, it's a shame we're coming towards the end of our term, because what we're trying to do through the partnership board and the subgroups is to have a subgroup for every major speciality, and those subgroups then deal with the PCB. And we then have a sort of network of communication with all GPs to try and bring particular areas of focus to people's attention. So it's just joining the dots, if you like, and making the flow of information a little bit more effective than it is at the moment to,
Okay.
as I say, to raise awareness and get everybody to, over periods of time, to have particular focus on particular areas, and trying to find specialists in each of the larger practices who want to, for example, in my own practice, there's one of the doctors is very keen on cancer analysis, and he's starting to go through all of the figures within that practice, and I've suggested that we let's go back to the PCB, and he then analyses cancer figures across the piece for all GPs. It's starting a network of engagement with the GPs, so that we get to better use, more sharing of the data, better use of the data, better analysis from that data, and better information going out to them about the things that are needed throughout the system. It's all part of this 4-year process that it's going to take time to build.
Yeah. Okay, thank you. And I think that will take us nicely into the next section, unless there are any final questions on endometriosis. No. Okay, so I'm going to move to my vice chair.
I'm going to jump to ADHD. We had you will be aware of our review that the panel did, and our understanding is that there's been recruitment of new staff, and I wondered whether you could provide an assessment of where we've got to in terms of the ADHD service and the waiting
Hand straight over
lists.
to Andy, who's going to give you a much more
course.
detailed appraisal.
So you're right, we recruited a nurse specialist who's a prescriber, and that was great news. Unfortunately, almost immediately after he started, we were beset by long-term sickness absence from another member of the team, so our overall capacity hasn't increased at all since he was taken on. The position then today is that we've got a waiting list of just over 1,100 people.
Which hasn't come down.
Which hasn't come down. So it's and we report this each month in our external reporting, and we talk about it obviously in the health board. The good news is that the specialist nurse has been doing some work with children's services, and at one point you may remember we had over 100 young people that were waiting to transfer from children's services to adult services. That figure's now down to 43. So we've done quite a lot of work on transitioning people over. So that's a good piece of news, I think. We're no further forward with the prescribing of medicines in primary care. It's been back to the advisory group and was rejected again. So consequently, we're almost in the same place in terms of we're having to spend more than half of the clinical time prescribing repeat prescriptions.
What was the basis for rejection?
So there was a couple of reasons given. One was the issue about the availability of medicines at that time, although in actual fact that's alleviated significantly, so that was really helpful. The second was a view by a number of the GPs that this is outside their skill set, and that they think it's something that they shouldn't be doing. It should be done within secondary care. And there was a concern about the level of demand and about whether or not they would be able to manage that within their current capacity.
So it's a bit of a catch-22.
So simply, and I think I've described here before, there comes a tipping point. So if we diagnosed about another 250 people and chose to treat them at the current rate, that would mean that all of the clinical time in the service would be spent prescribing. So we'd actually be at a point where we couldn't see anybody else for assessment because we haven't got capacity to do so. So that's a very much an ongoing issue that significantly limits what we can do in terms of the capacity available to us.
Are you taking any actions to deal with this?
So there are ongoing discussions. We talk, as you would expect, regularly with primary care colleagues in relation to is there a way that we can move this forward? We've recently had a conversation. We have 2 GPs who are interested in doing some sessional work, so GPs with a special interest essentially in the service. There are 2 factors that I need to work through in relation to that. One is in relation to funding, and I'll come back to that. But the second is having consultant availability to oversee their work and support them and train them and develop them, because clearly that's what needs to happen. You can't just deposit a GP in and say, off you go. It's essentially in part training. So that's that. I spoke with the ministerial team. We talked about this only last week, actually, in terms of I think we're now in a pretty steady state. When we have full capacity, and I'm hoping we'll have full capacity from next month in the clinic, we're not going to keep up. You know, we received 301 new referrals last year, and we've got capacity to see.
How does that compare year on year?
So it was slightly less, actually, but we've only got capacity to see about 12 new referrals a month. So clearly we're still in a position where demand really significantly outstrips capacity. I think we're going to have to think about what can we do, and I think the only place that we've now got to is we need to develop a business case for more resource in this service, because it doesn't feel like, at one point I was relatively hopeful that we'd kind of get on top of it. We're simply not. And the demand isn't going away. Clearly, there's a question about we could move resource now, but the reality of the financial position with the mental health services is we'd need to stop doing other things in order to put more resource into this pathway, and that's something that certainly wouldn't be supported by the leadership team currently, because the other things are things like crisis assessment, acute care, so that doesn't feel like it's a real option. So I think we're now in a position where we need to regroup. With the team, the clinical team, such as they are, have still been doing some work around prioritising the waiting list, for example, because we get very, very mixed types of referrals. But I think that's where we are.
I was going to ask what measures have been put in place to ensure that waiting list reductions are sustainable rather than temporary, but since there aren't any waiting list reductions, I can't really ask that. Is your view that it would be worthwhile looking at whether triaging more aggressively in that ADHD waiting list?
So we've done that, and we've done that twice. So in the last 3 years, if you remember, there was one point where we simply introduced gathering some information and asking people to provide a bit more information to allow us to triage. And the team do triage out. So there are referrals that actually don't get beyond the initial referral because they say, no, it's not ADHD, it's something else, or we want an alternative assessment first, and that's absolutely normal. We probably 18 months ago introduced more requirement to complete information within a timely way, provide information to the team for that triage to take place. So we've done that twice. And I think in some ways we're now in a place where, and the clinical team would say that's why there's a relatively high conversion rate. So people are generally diagnosed once they get through to the clinical assessment because they've already been through a number of sets of eyes that have said, could this be something else, and is this ADHD? The other thing that I must say, though, that I think is important, we, if you recall, started running groups around living with ADHD, managing symptoms, all of that stuff. The feedback that we've had has still been really good. We're on our 6th round of that group now. Unfortunately, the take-up isn't huge, so we've offered 300 people a place on the groups from the waiting list, and we've just under 50 people have taken that up. We're really actively trying to encourage people to go to those groups, not least because the feedback that we're getting from people when they do attend is it's great. It's a 6-session group that really looks at, how do you manage the difficulties that you're experiencing without the use of medicines. But that's a summary of where we are.
So you're hinting there at a possible another solution. I mean, to what extent do you think ADHD constitutes a crisis? I mean, on the face of it, this is a crisis. We have a service that is totally failing to meet demand. You are suggesting there are other treatments that are helping. But I mean, where does the answer lie in this?
So I think it lies in both. I think it lies in understanding the other things that we can do that aren't solely medication related, because people can alleviate difficulties through non-medical intervention. The evidence base is good around that. But I also think in the end, we have to think about how do we tackle this problem in terms of waiting for diagnosis. And I do think, and we keep bouncing around with this thing of how do we prioritise the waiting list? Because we have referrals for people, as I've said before, I think, who are, 65 and have gone to the GP and said, I think I might have ADHD. And the GP says, I'll refer you to the ADHD service. We also have referrals for young people who can't be in education, for example, because of the symptoms that they experience. So there's something about how do we work through and manage. And I think our clinical preference to date is to think about burden and about impact. But that alone is a huge piece of work that needs to be undertaken clinically, which will then remove the clinicians from the frontline work in order to prioritise the waiting list. So,
in terms of, have you finished?
I'm just going to ask the Minister what view he takes about whether this is something he would support.
Yeah, it's a real concern. We discussed it at length last Thursday, and we said we've really got to take a new look at this and come up with some suggestions as to how we might tackle it, because it just can't go on. A number of things have been tried, and you can see we're barely treading water. So it has to be addressed, and I would imagine the next. Don't want to put a timetable on it, but you'll be coming up with some suggestions, some concrete suggestions in the not too distant future. Yeah, hopefully before we depart from our position. So yeah.
Okay, so in the next month or two, you expect to have a plan of where to go.
Certainly,
with it.
yeah.
Which then,
proposal,
of course, as we've rehearsed multiply in relation to this, then relies on us being able to find clinicians with relevant expertise to come and do the work, because this is a problem everywhere and across the UK. Services are desperately seeking clinicians with expertise in this area in order to tackle exactly the same problems that we're experiencing here. So I've historically, as you know, gone to agencies, for example, to look for clinicians and been unable to get them simply because they're not there.
But at least we'll have a plan, an action plan that we will try to implement.
Yeah, some real quick training. Yeah.
In terms of training then, so you mentioned that there were some GPs that have a special interest minister. I think you mentioned this, and they are keen to be part of the solution. And I think you said, is it the supervision of those people during the training that's the problem? Could that supervision not be provided remotely?
Potentially. So if we had a consultant with relevant expertise who was willing to do that, yes, potentially.
Is that something you can actively explore?
So one of the difficulties that we get into is around the prescribing here, and the fact that for very good reasons our clinicians are disinclined to prescribe against assessments that have been undertaken by other people unless they're really clear that that assessment is robust. Not least by nature of the medicines that they're prescribing. That makes sense, doesn't it? But it's certainly something that we could explore. We've done that previously with the autism service. At one point, we had some remote support that was coming in. Who actually they weren't seeing patients, but they were supporting the staff that were. So potentially, yeah.
Okay. And Minister, when we've had public hearings with you, I think during the review, and it was very clear from you that you understood the urgency of this, and I think you mentioned having, calling meetings as soon as possible and taking some action. Do you still have that drive to find those solutions?
I think more than ever. We're sort of quite desperate that some of the measures we've tried to introduce actually haven't had an effect, and it's a big problem. So we're very keen. We're keen to get something sort of out in public as to the plan, and try and get the plan underway before we leave office.
Okay. And in terms of the groups that you're holding, have you tried to understand for those who aren't attending what they might need to attend? Because I understand you've got the good feedback from those who have attended. For example, are you offering groups that have similar demographics, like around gender and age, so that people might feel more comfortable attending?
So I don't know, but I will go away and find out.
Okay.
Yeah, thank you.
All right, thank you. I think that's everything.
Isn't it? Yeah.
Does anybody have any further questions on the ADHD review follow-up? No, okay. We're going to move on to the cannabis legislation, Vice
Yes,
Chair.
Minister, we note that P116 has been put off until later in the year. And I wondered if you could give us a brief overview of what the next steps will be and what work will continue in the department for handing over to the new Council of Ministers.
Can I just add something to that before you answer, Minister? So this is partly a question that has come in from members of the public. You'll be aware that there are numbers of islanders who are keen to understand, what is happening in this area and may not be aware of the rationale behind, why that proposition was lodged and why it has since been withdrawn.
The handling by the media of some of this has been a little bit confused. Because I've had a lot of correspondence from people saying, why is the government going to be opening its own, grow your own cannabis farm and stuff? And that's never been the intention. So I think there's been some confusion around it. The intention had been to debate it. And I think in the first instance, the reason that it was withdrawn is that there were three options. And one of the options, when we'd had it checked through for a second time, that we weren't comfortable that wording actually was legal, if nothing else. So we had to withdraw it. But I think Ruth has probably got a better handle on the points of detail, but that's the principal reason that it was withdrawn.
So we lodged the report and proposition. We received feedback on it, as we do quite a lot, actually including from briefing we did with Scrutiny. And as the Minister has said, it became clear in the feedback received that option one, which related to the decriminalisation rather than the legalisation of possession of personal cannabis, was not as clearly framed as it should have been to be able to support states members to fully understand what the option was. So we were concerned about creating confusion And we were also further concerned that because there was so little time to allow for full consideration by states members, because we were so close to the elections, that what we needed to do was to go away and do some more work. That work is being done at the moment, and we will have updated proposals, particularly around the first option, option A, to present to the new Council of Ministers post-election for the new Council of Ministers to make the decision to take that piece of work forward.
Can I just want to note the time. We've only got 15 minutes left, so if we could
yes.
pick up the pace then.
Can I just ask whether that work is going to include the consideration of what is the appropriate regulation for medicinal cannabis, which seems to many people to be something which really ought to be dealt with first of all?
Okay, so the work around regulation of medicinal cannabis is a separate work stream that we are working on. We have some draft proposals relating to the regulation of medicinal cannabis, which we are meeting next week, I think it is, to discuss with the Health Minister before we take those draft proposals out to wider consultation with cannabis prescribers in the island. So we are absolutely doing that. It is a separate stream of work.
Can I just make a comment that, like you, I think we feel that the medicinal cannabis issues need to be resolved, but I'd just ask everybody to bear in mind that the work that we're doing on the other cannabis, recreational cannabis, as a consequence of a states member taking the proposition and asking us to go away and do that work. So we're not prioritising that in front of the other work. We're actually responding to the wishes of the Assembly. So that's, I think what I would say is whoever's sitting in the ministerial team next time round, because this is so complicated and it's got such a lot of sort of arms to it in terms of medicinal and recreational and so on, that the messaging, the public messaging, has to be very, very clear. And we need to contextualise what's happening, because the truth of the matter is, in dealing with the illegal market now, or the recreational market, it's fair to say that market has almost disappeared. It's the medicinal market that's supplying, as it strikes me, supplying the bulk of the market anyway. So, like you say, you come back to where our priorities ought to lie, and where our priorities would be is dealing with the medicinal side.
Yeah, well, I think we're all agreed that unfortunately the medicinal cannabis came in without the regulation that should have accompanied it at the time.
It was a
and it's really important that we
triumph of
get it right.
enthusiasm over forethought, I think. Yeah.
Can I ask one question about other things that might be being considered at the same time, which is once you decriminalise or legalise cannabis, the smoking of cannabis in public becomes by default also legal. Is any thought being given to whether it would be appropriate to bring at the same time as you bring potential state legislation changes forward, a measure that would at least offer the option of criminalising or making illegal in some form the smoking of cannabis in public, even after possession was made either legal or decriminalised?
That's assuming it's the Assembly that makes the decision, not us. So it may decide not to decriminalise, but on the assumption that it was decriminalised, that's something that could be looked at. But I think there are complexities there as well in terms of the policing of it. And the practicality of it. So those are all things that would need to be looked at as a second stage.
So they're not being looked at as part of the current stage?
They are being looked at past the current stage.
And what could you just give me a very quick, given the time?
So they are being looked at the current stage, and we're looking at a range of options, which is: can you smoke in public? Can you vape in public? Can you vape in some public areas and not in public areas? So we are doing an analysis of what that looks like, and we are also looking at how other jurisdictions have responded to that. You might be aware, for example, that Amsterdam has just changed its legislation to prevent the smoking of cannabis in public because Amsterdam stinks. So.
Whole state.
Of cannabis only.
Careful.
Okay, Okay, thank you. Thank you for the answers there. We have some questions on sign language interpreters in the hospital, which have come via Constable Shenton, who isn't able to be with us today. Minister, could you help us to understand whether there is a sign language interpreter that is available to individuals in the hospital who need it?
I've discussed this a number of times with Constable Stone, and I've met a lady who does a lot of advocacy work for the deaf community twice in recent weeks, and that's resulted in a whole new piece of work being undertaken. Don't know if you want to make some comment, Tom. It's in its early stages, but I think it's what became apparent to us is that the deaf community have been sort of a little bit ignored over the course of time. So there's a new push, but it's only in recent weeks that we've really upped our game on that, and we're now giving full consideration to a number of issues that have been raised to us, particularly by this lady advocate for the deaf community. So all of the things that she's brought forward have been put through to the leadership team, and they're all now receiving consideration. I can only apologise that that's been a little bit late in the day, but as you know, we've got a very full agenda, but it is now being addressed, but it's in its early stages.
Okay, thank you. And what's the timeline for a fully operational interpreter to be available on site?
Shall I take that?
Yeah.
So this has come to me
Detail
in the last few days. So currently we use Sign Video. So this is an app-based interpreting service, which is used across the government for other things as well. But essentially, it's a BSL app where people can log on and their interpreting occurs through the app. So that's the main way that this is done in the hospital currently. But Tom Walker and I are meeting with representatives of the community within the next 2 weeks to start to understand what are the concerns, what are the issues, and what do we need to look at.
Okay, and is that community advocating for an individual locally to be providing that service rather than an app?
As I say, the detail of that is, as I say, I had arranged for this lady representative to meet the team, and it's running faster than I am because I didn't even know that it had been put to you, Andy, to run. So that's happened since last week.
Okay, thank you. And there are a number of issues that have been raised with us, for example, around the use of family members for interpreting and how that might interact with consent and coercive control, etc. The documentation that might be available, partnerships with those services and how they're accredited. In terms of all of those details and the training, could we be kept updated on that?
Absolutely. Yeah.
And will you be consulting with the deaf community throughout?
Yes, I would certainly hope so. I can't imagine we could do the work without doing that. So yeah.
Okay. Thank you for the reassurance on that. Yes.
Long-term thinking around health spending, the budget has obviously had a big boost, but the pressures are still very much there. What long-term strategy, what work are you doing to address the long-term funding of healthcare?
Well, some thinking is going on within the leadership team about that, and I've been having discussions once again in its early stages with two clinicians, one who's retired, who've been doing work independently. So I met with them very recently. They'd be happy to join a collective approach. I thought it's pointless, lots of people going off at tangents, particularly experienced people, and coming up with their own work streams. So the plan is to put them all in the same room together and actually have one body of work going on with people that are actually involved with the service directly and those that are familiar with it and doing work on the outside. So it's his early days.
Did you want to talk to Hazel?
Well, I'm interested in the Minister's take on it first.
Yeah.
I mean, this is not a new problem. It might be slightly concerning for people to hear that it's only early days considering the long term.
It's early days for making it more collaborative, okay, and looking at the sort of more political element of it, because there are certain things that can be done internally, but then there's the political angles as to how we take that forward and on what basis we take it forward. It's I have to say it's going to we won't be able to get enough done in our own term of office, but who knows, we might try and persuade people to let us come back and carry on. And if we do, I know the point was made, it was very easy for us to get money in the first instance, and why didn't we think about funding before taking extra money? I made the point that you need the money now to get the service running properly, and that the next step would be then to to look at getting more money in, more resources. So I know it might look like a cheap political trick to do it that way around and cast that problem onto someone else, but I'd be very happy to be in a position to come back and face the music on that. That doesn't bother me at all.
Suggest such a thing.
Very kind of you. You see what I'm saying? I'm
Yes,
talking
I hear
about
exactly.
the political principle here. If we'd have been 4 years in the job, it would have been slightly different. But what we thought was necessary was more money right now. We've covered a lot of these problems today that just require some funding to get things moving, which I think we're hopefully, as a collective, we're succeeded in doing. We do need to look at health funding. We do.
I know the early bid for reappointment, but the
It's just a common sense approach to wanting to continuity. But
I think the only takeaway I'd say for that is it does sound very ad hoc to people who have expressed an interest and so on. I mean, what is the structured programme of work that is going to investigate the funding of health services in the future?
no, we've got Philip Housden doing work on this stuff. But we've also, I think, but it's better at this. I don't want to dig a deeper hole for myself. I hand over to Hazel.
Probably a joint piece from Ruth and myself. So Ruth and I are working together on this, both from a sort of policy and financial perspective, and we're also working with Treasury colleagues. So we have, as officers, we've established a project board. There has been work already, as the Minister has pointed out, and I think we've discussed it at previous panel hearings. There is work in building a model which will give us that trajectory of what health and care spend across the sector would look like into the future, in order for future government to look at potential policy options. So I don't know, Ruth, if you want to then add
just
to
in
that.
terms of the work that we're doing on developing the model, we also have two auditors from the Control and Auditor General, because the Control and Auditor General is particularly interested in this area, who are working alongside us and examining that work on the development of the model as we do it, even though it's a piece of work that's still in flight. But that's in terms of the recognition of how important it is. So the plan is that by the time that you get a new Council of Ministers, we will be able to say to them with authority, this is what your healthcare spending looks like if you continue as you are today. This is what happens if you crunch in different population numbers. This is what happens if you crunch in different efficiency targets. And it will be on that basis that the new incoming Council of Ministers can make some very firm proposals about how we afford things as we move forward, because there is no doubt that there's a big funding gap, and we have to do two things. We have to reduce expenditure at the top, but we also have to think about how money flows into the system at the bottom to close that gap.
And when does the public get involved in this? Because these are
So
potentially vast decisions that affect society.
They are absolutely vast. Obviously, I can't speak on behalf of a future Council of Ministers, but we would like to think that we're in a position to be consulting on options around funding towards the end of this year, end of this calendar year. So by quarter 4 next year. Quarter 4 this year, getting my years wrong. In addition to that, as you know, we are doing other pieces of work, looking at existing policies, and also looking at how we introduce policies that create the right behaviours in terms of use of resources, such as the charging people for incorrect use of ED, charging people for do not attends. This is all part of, these are small bits of work, but they are all part of a whole programme of work, which is not just focusing on what more do we need, but how do we use what we have more effectively and targeted those in most need.
Just important to say that the charges, just thought I'd get this in, the charges you're talking about are to drive behavioural change.
Yeah.
They're not, those aren't revenue raising,
yeah.
they're actually sort of a means to try and make the system work more efficiently. So just want to make that plain publicly.
Can I inquire about the ministerial group on the wider social determinants of health? Is that group, I mean, has it had any output yet? And how is that going to feed in?
No output as yet, but we have had an initial meeting to just discuss between ourselves what we think it should be doing, the approach we'd like to take. But I think in the next government, now that things, I think there's a certain maturity across the piece here in terms of what's happening and where we're going, and that can now be used to feed into that group. The worry about that is if there is no continuity, there'll be a break in the politics of it working, because I know what it felt like. I'm sure Andy would bear me out, sort of being parachuted into this job just over 2 years ago. There is so much to learn if you're not got a background in it, an enormous amount to learn, and until you've actually got your feet on the ground, you can't take that information up to take through to your other colleagues to join the dots, as it were. What we are trying to do is to produce a readable document that can actually say to somebody when you come in, this is the structure, this is the work program, so that if it isn't us, it's somebody that can actually say that can be sort of run through the politics of it to know what they're dealing with, and the wider determinants of health group will feature as part of that. But as I say, it's the worry is it's for lay people, it's so complex that there'll be a sort of hiatus there, which is a concern.
Confident then that group will have some output that can be examined alongside the numbers and the facts to actually determine what wider social change might need to happen in order to impact those figures?
In principle, it can be a very, very useful grouping of people. I genuinely think it can. It's just a shame that our period from the political side isn't that little bit longer, because we're at the stage now where that could have been made to work quite well. But such as it's politics.
Okay, any final questions from anybody? No. Okay, so Minister, before we close the hearing, I wanted to put on record that although we are not launching formal reviews of any of the legislation that you have lodged, we are scrutinising it, and we're doing it in this way because of the shorter time period. So, so members of the public won't see formal reviews being launched, but we are scrutinising the health and social care register and the termination of pregnancy law, and we'll be aiming to publish some comments on those, and we'll keep you up to date with that.
Good.
Okay. Anything that you'd like to add before we close the hearing, or your Assistant Minister?
Just to say thank you very much.
Yeah, hopefully it's been constructive, and for anybody listening, and I hope they found it constructive as well.
Yeah. Well,
Good.
thank you very much for your answers, and to officers as well for your answers and for your time, everybody. And I'll close the hearing.
Thank you. Thanks.
Panel as well. Sorry.